And again, we're back with Dr. Tim McKnight this morning. It's always good to see you. Thanks for coming in.
Good morning. How was your holiday?
I was going to say it couldn't have been better. It couldn't have been better. Yeah, it was
Great.
It was great. Good food, good weather, good everything.
Beautiful weekend.
It was great. So we turn to heart disease, which is the number one killer. It's something that everybody needs to be concerned about. And how do you find out about that? How do I know if I have the beginnings of some sort of heart disease?
Well, you see somebody that knows how to help you, knows how to screen for heart disease, which would be your primary care provider or a cardiologist. And there's two different ways that we can, or paths that we can follow. Actually, three. The first is your history. What does the pain feel like? What are your symptoms? And then, and one of those primary risk factors is a strong family history. So someone before the age of 65 in your immediate family, a first-degree relative, a sibling, a parent, or even a child who's had an early heart attack or an issue with a blockage before the age of 65. After 65 is not quite the same risk. So if that's in your family, you got to be really careful. And then we have diabetes, hypertension, smoking, high cholesterol as the other risk factors. So the history and the risk factors are the first clue that we need to take this seriously. And then we have blood tests that can kind of help us screen for it. And we have the more definitive tests, which are imaging tests. So the most common one is a stress test. Mm-hmm. And there's different types of stress tests. Some people can't walk very far on a treadmill because of knees or hips. So we give them a chemical stress test. And we'll give them a chemical that speeds up their heart. It's a very uneasy, scary feeling for a couple of minutes as the heart just starts to race as you're laying there, and you're not sure if it's going to stop. And we always try to reassure patients, but once it's over, you're okay. And the other one is an exercise stress test, and we can do these with and without images. So if it's just a plain old exercise stress test, we walk you on a treadmill and slowly increase the speed, increase the incline on the treadmill. We're trying to get your heart rate up to a high enough level that we can see that it's stressed because of exercise. And then we either look at changes on the EKG or we look at changes in the imaging. Sometimes we'll do an imaging study where we'll give you an IV contrast dye that will light up your heart like a Christmas tree. And if there's a portion of the heart that doesn't get blood flow, that doesn't light up like a string of lights on a tree where there's some lights out, then we can say, well, there's a flow problem here. This could be an issue. And then from there, if we think there's enough of concern that there's a blockage, then we'll recommend a heart catheterization. But there's one other test that I found is really useful, and it's called a CTA angiogram, or a CT scan with a dye study. And it's basically just a CAT scan where we're just looking at the heart itself. We're injecting a dye in, and then we put you through the CAT scan machine, and we're actually looking at the three major coronary vessels and some of the major branches off of those. And we're seeing if the blood flow is restricted in those areas. That's a real good way to screen for this. There is a challenge sometimes with the typical stress test with imaging, because if you have blockages in every coronary artery and they're equally blocked, you're not going to see that contrast. Mm-hmm. It's all going to look homogeneous. It's going to look the same. So there's a false negative rate with some of these stress tests. It's not a perfect imaging study, but the CTA angiogram is a really nice way without really the person's not doing anything but laying down, and we can tell you if there's a blockage. And unfortunately, insurance companies don't always pay for these. You have to have good enough reason. But if you've got a fairly strong family history or something that makes you concerned and you just want some information, if the insurance doesn't pay for it, you can pay for it out of pocket. And I've had half a dozen patients say, it's worth it to me. I want to know. They're concerned for some reason or another, and they can have this study done. And Mercy Medical does it. I think Altman does it. Most of the bigger facilities will do this, again, with or without insurance. But it's really reassuring to the patient that, hey, I'm okay. That I'm short of breath because I'm getting older and I'm not in shape and I'm walking up the hill too fast. Not that there's a blockage.
Yeah. Well, yeah, that's things to be concerned with. Other warning signs, I know with the heart attacks, there's the pain on the left side and that sort of thing. But with heart disease, is there necessarily depending on what kind of where you're being attacked, I guess.
Right. Yes, they're different based on those three arteries. There's typically different symptoms that occur. If it's the widowmaker, it tends to be different symptoms versus one of the arteries in the back of the heart. But really, it should be a fairly predictable kind of a discomfort or a breathing issue. Sometimes for a lot of people, it's just fatigue. They're tired. They'll go vacuum the house and they have to sit down and rest because they just get tired. And once they get up and once they've rested, they feel better and they get up and try to finish the room and they get tired again or they get winded. So these are normally exercise induced or activity induced. When you're feeling something with activity that gets better with rest, that's often a sign that you got to really be careful. But there's all kinds of symptoms. It can be jaw pain with exertion, or neck pain, or chest pain, or back pain, or shoulder pain, or arm pain. And we call these, a lot of these are considered referred pain because the pain, it really exists at the level in the heart, but the body refers the pain to someplace else. And what's happening is the nervous impulses that say my heart hurts, when it connects and goes to your spinal cord and goes up to your brain, sometimes those fibers get crossed and the brain interprets the pain someplace where it's not. So that's referred pain. So you just really have to watch it. And again, the clue is a different discomfort or symptoms with exertion that you haven't had before that gets better with rest. Chest pain or heart pain is not a 5-second stabbing in the chest.
Yeah.
It's usually minutes, and then it gets better with rest. So, but these aren't really decisions for the patient to make. These are decisions for the primary care provider or the cardiologist to make. So if something feels different, especially if there's a history of heart disease, or if you've got multiple risk factors, if you're a diabetic smoker that's got uncontrolled hypertension, those are a pretty good indicator that something's happening as well, and you don't want to blow that off.
Let's say it's history, because obviously if you're a smoker and you've got sugar, you've got issues there. But let's say your family has this history. Are there things you can do to try to prevent this? Because some of it is hereditary.
Absolutely. So we want to control those 5 major risk factors. You can't control your family history,
Right.
but you can screen early with that CTA of the chest. And then high blood pressure, diabetes, smoking, and cholesterol can all be controlled with lifestyle first and medication second. And often we jump right to medications. We don't even give the patient a fair chance to make the lifestyle changes, which are more, they're much better to do that, obviously. And there's some blood tests too. Everybody's familiar with the cholesterol profile, which is it's a good indicator, but it's not you can have high cholesterol and have no heart disease, and you can have normal cholesterol and have terrible heart disease. So it's not the best screening tool, but we can do things like test a blood test called the highly sensitive C-reactive protein, the CRP. That's a marker of inflammation in your arteries. If that's really high, that can be an indicator that you have arterial inflammation, which is plaque progression. It doesn't always mean that, though. So if the number is between 3 and 10, we think, okay, we need to look into the heart. If it's greater than 10, it can be an autoimmune condition. You can have lupus or rheumatoid arthritis or something else. So you don't want to overinterpret that particular test. There's another really good one called the homocysteine level. And homocysteine builds up because of usually a metabolic defect, an enzyme defect. And when homocysteine levels are high, it injures the lining of the arteries and causes more inflammation. It's the beginning of plaque buildup and progression. And a lot of us have a defect of this enzyme. I have this defect, so it's about 60% active. So there's more homocysteine building up in my blood in my entire life. And it's a really easy fix, though. If you take a B complex every day, you can drive that down. It's a really neat little chemical pathway that says if you give me folic acid, B12, or B6, I can move that pathway so that I can get rid of that homocysteine. And so it's a simple thing to do. So again, we come back to a healthy lifestyle, a good weight, because the heavier you are, the more inflammation you have in your body. Heart disease is an inflammatory process. It's a blockage of arteries because of inflammation. It's not the cholesterol. The cholesterol just becomes part of that whole mix. people and your body sees cholesterol and it gets overinflamed, that's a problem. So that's why you can have high cholesterol and not have heart disease if you don't have an overinflammatory state. So, don't smoke, healthy lifestyle, active, good weight, eat well, and I don't think it hurts anybody to take a B complex every day. And one of the reasons is for this homocysteine issue.
And those are vitamins, and they're inexpensive.
They're inexpensive, yeah, and especially once they're inexpensive, it's just trying to get in the routine to take them every day. Most of us who take vitamins we're really compliant at times, and then we kind of fall off the wagon and forget to do it, and we have to remind ourselves, this is why I'm taking it, because it normally doesn't make us feel better. We have to be reassured that we're doing something helpful to our biochemistry.
That's true. See your primary care physician and start from there to see what you need to do thereafter.
Yeah, and don't blow it off. A lot of times we minimize these symptoms, and then there's some people, a minority of people that will have symptoms and just they'll ignore it, and they're the ones that can drop. And if you're in the late 40s, early 50s, 60s, and something's changing, you really don't want to blow that off, because those are the age groups where people have one heart attack and that's it, they die. And that's because that plaque in the artery is very soft, and when it rips off, it occludes an artery, a big artery, and it kills enough of the heart muscle where you can't survive. So don't let yourself be a victim because you're too cavalier and not going to take it seriously.
Yeah. All right. Well, thanks, Dr. Tim McKnight, for getting us caught up on heart disease and the tests that we need to go through to make sure that we're going to be okay. We appreciate that.